Hello. Hi, everyone. I'm Dr. Angela Leung from Boston IVF, and welcome to our Facebook Live Q&A session tonight. I'm really excited to be with you all and to answer all of your questions. Please feel free as we go along to enter your questions in the comments, and I will get to them if able. So I just wanted to first start off by introducing myself and telling you a little bit about who I am. Again, I'm Angela Leung. I'm one of the fellows at Boston IVF, and you may be wondering, well, what does that mean? What is a fellow? And for people who are not very familiar with the medical training system, um, a fellow is essentially, so I'm a fully trained OBGYN who's just chosen to do further training in the field of reproductive endocrinology and infertility. So what that means is that I've completed medical school, residency, and if I was not doing this additional training in fertility medicine, I would be a practicing OBGYN right now, potentially taking care of any of you guys for your gynecologic or obstetric care. But because people like me are really interested in fertility medicine and helping people like you build your families and think about your fertility, we've chosen to do the additional 3 extra years of training to become experts in this field. So again, fellowship is 3 years. I'm in my last year, so I'm the senior fellow here. And at Boston IVF, our fellowship is in conjunction with the Beth Israel Deaconess Medical Center and Harvard Medical School. So you may be wondering, well, what does that mean in terms of your care if you come to see us at Boston IVF? How is the fellow involved? We're involved in pretty much every aspect of clinical care. So places that you might most often encounter us are when you come to get either ultrasounds or certain types of tests, as well as procedures like your egg retrieval, embryo transfers, intrauterine inseminations, or even when you come in for surgery in our surgery center. Another area where you will frequently encounter us is if you happen to call in on nights or weekends. You would usually call the call center to speak with the physician on call, and that's usually one of us. We also have our own clinic as well, and we have our own panel of patients that we see. One of the benefits of seeing a fellow as your primary physician is that we actually have a lot more time than some of the other attending physicians, and so we can spend more time with you and give you a little bit more TLC. And for some people, they appreciate that. As always, fellows are always supervised by an attending doctor as well. So, you never have to worry that, that you're not being taken care of to the best of our abilities. If you want to learn more about us, again, I'm the third year fellow. We have one fellow per year. You can look up more info about us on the Boston IVF website. Before I get started with questions, I just wanted to give 2 disclaimers as well. So, the purpose of tonight is to answer, all of your fertility questions to the best of my ability. But this is not medical advice, remember. So if you happen to have a very specific question about your personal medical situation, I will be able to kind of generally explain things, but I won't necessarily be able to advise you on what you should do for your specific situation. The second disclaimer is that obviously Boston IVF, we're located in the state of Massachusetts, which is a mandated state. And what that means is that there is generally insurance coverage for fertility treatment. If you happen to be watching from a place that doesn't have this kind of insurance mandate, then some of the things that I'll be talking about may not necessarily apply, or um, you may actually need to consider um, kind of the treatment course or options a little differently. And I'll try to make that distinction when I can. So I first want to start off with kind of addressing a very general question that most people have, which is, well, what should I expect at my very first appointment? And often the first appointment can be very daunting because it's the first time you've ever considered seeing a fertility specialist, and it really seems like a big deal. First of all, to acknowledge that you may need some help to achieve pregnancy or whatever your goal is. Um, right now in the pandemic, all of our visits have been virtual, and we will likely be continuing that for some time. So the benefit right now is that you get to attend your initial consult from the comfort of wherever you want to be, at home, at work, wherever. And so it will be a Zoom consult with the physician that you pick. And it's generally about an hour long. And during this visit, the physician will, ask you about your goals and about your medical history, and just really learn more about you and your partner if you happen to have a partner. Um, so just a side note, if you do have a partner, it's also really important for the partner to attend that initial visit as well, because again, when we talk about family building, often, if there's more than one person involved, um, both of those people contribute a significant parts of the process. So we like to be able to address couples if that is, your situation. Um, Most of that 1 hour is going to be, again, getting to know you, getting to know your medical history. And then usually, if you haven't had any fertility workup yet, the discussion will be about what kind of fertility workup is appropriate for you. In general, most people get some kind of workup that includes evaluation of their ovarian reserve. This is for a female patient. So essentially, the quantity of eggs, or a sense of whether you have a good supply, a fair supply, or a low supply of eggs. An evaluation of the uterus and tubes to make sure that there's nothing anatomically abnormal about the uterus, and that the fallopian tubes are open. And then also, of course, an evaluation of the male partner if there is a male partner with a semen analysis. And everyone gets blood work as well to kind of check general infectious diseases, and to make sure you're immunized against things like rubella, hepatitis, things like that, that would be important to be immunized against if you were to get pregnant. Um, that's a very general overview of what might be done. And again, for your specific diagnosis or situation, things might be added or subtracted. And again, part of your goals, will also direct kind of where that testing goes. So let's see about the questions that are coming in so far. Okay. So Nene is asking, how long does it take to get results from an antiphospholipid antibody syndrome workup? So just to explain a little bit for the viewers who might not know what that is. So antiphospholipid antibody syndrome is a condition that is thought to contribute to recurrent miscarriages. And so, usually, if you're getting that type of workup, it usually means that you've had a history of 2 or more early miscarriages. So, your doctor would recommend getting that kind of testing. It's all blood work, and usually depending on, if you got the blood work with us versus at a hospital or outside lab, it can take anywhere from a couple days to a week or more. Um, so it's not, for us, at least at Boston IVF, it's not one of those tests that we do in-house, meaning we have to send it out to a different lab. So it's not a same day turnaround. It can take a couple of days. Um, Vanessa, hi Vanessa. She's asking, for an IVF cycle, can the egg retrieval be done with local anesthesia only? That's a really good question. If not, what kind of anesthesia do you use? And she's apprehensive about anesthesia. I can totally understand that. And that's a really great question about local anesthesia. So at Boston IVF, our standard practice is to use general anesthesia. So what that means is you get medicine through the IV that puts you to sleep. Now, this is very light sleep, so it's not the same kind of anesthesia that you might get in a hospital for example, a surgery to remove your appendix. For that kind of anesthesia, you're completely asleep, you're paralyzed, and you're not breathing on your own, so you require a breathing tube. For our egg retrieval procedures, it is not that deep of a sedation, so you are still breathing on your own. There's no breathing tube. You will have an oxygen mask on your face just to help, help with the oxygen a little bit. But you are fully asleep, so you don't feel anything, you don't remember anything. And we do have fully trained anesthesiologists who work with us to administer the anesthesia and monitor you throughout the entire procedure. So it's not us. I'm not trained in anesthesia, and you would not want me giving you anesthesia. But our wonderful colleagues help us with that. The question of, can we do it under local? Certainly we can, and we have done that before. For example, sometimes, people are just really adamant about not getting sedation, or maybe there are medical reasons why they can't. More often than not, sometimes it's because they accidentally ate too close to their procedure. So whenever you get anesthesia, you have to stop. Your stomach has to be empty for a certain amount of time. So usually we say, on the day of your egg retrieval, no eating or drinking after midnight. Sometimes people accidentally forget and they had breakfast that morning, and therefore it's not safe to give you anesthesia, general anesthesia. And so sometimes you will go ahead with the procedure by doing local. Now, with local, you have to be aware, though, even though it numbs the area inside the vagina where we put the needle to get to the eggs, um, often people still feel, a little bit of discomfort, and you are awake throughout the entire thing. So it can be a little distressing from that standpoint, which is why we, recommend in our practice is to do the general anesthesia. But certainly there are places in the country and certainly other countries where their general practice is to use local. So, it can be done either way. And if that's something that is really important to you, have a discussion with your doctor about that. All right. So I hope that answered your question, Vanessa. Okay, let's see. There's a question from Tracy. Hi, Tracy. She says the ultrasound tech told me that my right tube was blocked and I needed it removed. at first, my doctor agrees, but after my failed transfer, she looked at the ultrasound again and said maybe it wasn't blocked, but she can't really tell. When I go to do another cycle, will I have to get the test done again to see if it's blocked or not for sure? So, um, I'm not certain what test exactly you're referring to because there's a couple of the test that we use to definitively tell us whether your tube is blocked or not is actually not an ultrasound. It's an X-ray test called an HSG or a hysterosalpingogram. That's a test where we instill some dye through the cervix into the uterus and watch it spill out both tubes. And obviously, if we can see see the dye coming out of the tubes, then your tubes are open. Some people have a condition called hydrosalpinx, where for some reason there was some injury or scarring that happened to the tube, and the end of the tube is either completely scarred shut or mostly scarred shut, so that when the dye is pushed through the tube, it balloons out a little bit. And you can see that on the X-ray tests. I wonder if that's what you're referring to, Tracy, because in those instances, sometimes we will recommend the tube be completely removed. And that is because in that dilated tube, some fluid can collect, and that fluid is thought to be toxic to embryos. And so there have been studies that have been done that show that the implantation rate of embryos in patients who are undergoing IVF treatment are actually cut in half if you leave a dilated tube like that in place versus if you remove it. Um, Now, again, I don't know your specific situation, and so the nuances of your case may kind of indicate you going one direction or the other. And again, it's really hard to say, if a transfer didn't work, for example, if that block tube really was the reason. Because you have to remember, even though we talk about, oh, studies show this or studies show that, the studies are of patients, are infertility patients who come to see us already. There are probably many, many patients out there who never see doctors like us and have dilated tubes and have no issues conceiving. And so, it's always hard to tease out a little bit exactly how much true impact these things have on unsuccessful attempts. And so just always, always take these things with a grain of salt. All right. Next question. Devin asks, is there help out there for those financially? I'm in Maine where there is no mandate. That is a really good question, Devin. And, we're working on it. We're working on Maine. Um, Recently, I mean, just about a year ago, the mandate passed in New Hampshire. So, hopefully we're kind of moving up the East Coast and we can eventually expand insurance coverage for everyone in the New England area and really across the US. As for now, if there are other options to get financial assistance for fertility treatment, there are definitely programs out there that you could see if you're eligible for that might offer some type of assistance. If you've never checked out Resolve, I would recommend you do that. They're a really great patient advocacy and support group. And often they have, scholarships or programs where they provide financial support to various patients. Um, One other thing that you should also look into is, if you work, does your employer actually offer anything specific related to fertility that might be separate from your normal medical insurance? So, for example, there are a lot of companies now, especially in the tech industry, that offer essentially an insurance program called Progeny. Um, and Progeny is separate, from your normal medical insurance, but will help cover fertility treatment. And so that's another place to ask as well. Um, and then lastly, at Boston IVF, we're always doing, we're heavily involved in clinical trials as well and doing a lot of research. And sometimes we have research studies where if you qualify, you may actually get an IVF cycle paid for or at least at a very reduced cost. And so, if you're one of our patients, definitely ask your doctor if there are any studies that you might be eligible for that could help with some of the financial burden of treatment. Okay, Brittany asks a great question of what is the waiting period currently after you submit a referral? Isn't that the question that we all, wonder for our own medical care? So, honestly, the answer to this really depends on which doctor you requested. Um, if you happen to request a doctor who's very, very booked up, or for example, maybe is just doesn't have as many clinic days open, then the waiting period could be over a month, potentially 2 months. We really try to keep it within a month. Um, that's again, I'm going to go back to the fellows clinic. That's another benefit of actually seeing a fellow is that we can often get you in within a week or two. And so, if you're interested in seeing one of us, we can generally facilitate things pretty quickly. But basically, it really depends if you had a preference in who you specifically chose to go see. Okay, Jacqueline asks for hormone treatment prior to transfer. Is injection the only hormone delivery method, or is it just the preferred method? And how painful are the shots? Um, so Jacqueline is referring to the progesterone hormone treatment that we often give prior to transfer. And the answer is, Jacqueline, no, shots are not the only way we can give progesterone. The other common method is vaginally. But there might be reasons why your doctor chose one method versus the other. So, for example, there are different types of transfer protocols, especially if you're doing what's called a frozen transfer. So that means the embryo was created in a prior IVF cycle. You froze it, and now at some time later, you're ready to come back and use it. If you do the transfer protocol that mimics your normal menstrual cycle, where you ovulate an egg and then we just time the embryo to be transferred at the appropriate time, most of the time you don't need any progesterone supplementation, or you can do just vaginal supplementation. Um, However, if you use the transfer protocol that's called a program cycle or medicated cycle, meaning we're totally ignoring your natural cycle completely, you're not ovulating an egg. And so what that means is your body is not naturally producing progesterone. So we have to supplement all of it for you. And usually in those instances, the shot progesterone form is recommended because it really gives you kind of a bigger boost in the progesterone dose that your body will see. Usually we give you both the shot and the vaginal form in that case. Sometimes it's only the shot. It it really depends on your specific situation and your doctor's preference. How painful is the shot? I'm not sure if I can really adequately answer that question for you as I've never experienced it myself. But the shot is a intramuscular shot, and so it goes into your bottom. Um, and usually, just because of the awkward angle, people do need to, have their partner or friend or family member help them administer the shot. Um, my guess is that it's probably similar to getting the flu shot or any type of vaccine. And most people do really, really well with it. I can't say that it will be fun, but most people tolerate it pretty well and don't have too many complaints as far as I've heard. Okay. All right. CJ asks, for a frozen embryo transfer, do you need to be at a certain BMI before Boston IVF will proceed? That's a great question, CJ. And I think the reason you're asking is because you might have read or heard that for an egg retrieval, we actually do, have a certain BMI that you need to be under for us to proceed with an egg retrieval. And you're wondering if that's also the case for a frozen embryo transfer. Let me just explain a little bit about the rationale for why we have a number for egg retrieval first. Our policy is that you need to be at a BMI of 45 or less to undergo an egg retrieval. And this certainly, it does not reflect, it doesn't mean that, we don't think that a person who has a BMI 45 or over will be unsuccessful, that they can't have a baby or anything like that. What it really refers to is anesthesia risk. And that's primarily because our egg retrieval and our procedure center is an outpatient surgery center. So when your BMI is higher, generally there's more tissue around the neck area and around the chin that when you're asleep can make it more difficult to breathe. And so our anesthesia colleagues become concerned when people have very elevated BMIs, that when you get the general anesthesia in your sleep, you're at much higher risk for airway compromise. And again, because we're not doing these in a hospital setting, if something were to happen and you needed emergency intubation, which is where a tube is put down your throat to help you breathe, or something like that, we are just not in an ideal setting to take the best care of you that we can. And so, because of that, we do put an upper limit on the BMI for egg retrieval. Now, that being said, because in a embryo transfer, there's no anesthesia involved. It essentially is like a pap smear. You come into one of our exam rooms, an ultrasound is put on your belly. We insert a speculum. We put a catheter into the uterus, watching the ultrasound the entire time, and then the embryo is loaded into that catheter and placed into the uterus. And so you're awake the whole time, there's no anesthesia. And so there's really, there isn't that risk that I talked about before. So generally, we don't have a cutoff specifically for frozen embryo transfer. Now, the likelihood is that, if you had created these embryos with us and done the egg retrieval procedure, you probably already, were under that BMI of 45 anyway to undergo the egg retrieval. So you're fine for the frozen embryo transfer. If your IVF happened a couple of years ago and now your weight has changed a little bit, again, it, it doesn't matter as much in this case. So, you should be okay. Okay. So Devin asks a great question about miscarriages. So Devin is asking, are miscarriages lessened through IVF or odds still the same? Um, and it sounds like you've had testing for this, and unfortunately, nothing has really come up as the reason for why. And I'm really sorry about that. But do know that you're in good company. A lot of people who have multiple miscarriages undergo all of the testing that's usually recommended, and no answer comes up. And it's really frustrating because again, there's no answer, which kind of means that there's nothing to treat specifically. Um, and again, that makes the entire process extremely frustrating. Now, does IVF lessen the risk of miscarriage? IVF by itself does not. So your chance of miscarriage is still your age-related chance when you do IVF. So what I mean by that is, um, as you may all know, the chance of conceiving decreases as we get older. And along with that, the chance of miscarriages also increases as we get older. And that's kind of what accounts for some of the difficulty in having a successful pregnancy with increasing age. So to give you some numbers, for example, a 20, say a under 30-year-old probably has about a risk of 10 to 15% of miscarriage in the first trimester. When you get to 40 or above, that chance of miscarriage becomes close to 40 to 50%. And so it is quite dramatic based on age. And IVF does not change that. Now, the caveat is if you're going to do IVF with genetic testing. And so that's referred to as pre-implantation genetic testing, or PGT-A. And what that involves is when you go through the IVF process and you create embryos with the eggs and sperm, we grow out the embryos in the laboratory. And if you choose to have this testing done, on day 5 or 6 of the embryo development, we take a little biopsy from the from the embryo, which just means removing a couple of cells. Now, your initial question might be, oh my gosh, is that safe? You're taking cells out of, a potential baby. And the answer to that is, as far as long as we've been doing this, which has been, a few decades now, we haven't seen any adverse effects of this type of biopsy on pregnancies or the babies that have been born from this. And the reason is the cells that we're taking from the embryo are cells that become the placenta. So we're never taking any cells that form the baby. And the thought is that the cells in the placenta mimic the genetics of the cells in the baby. So we remove these cells and then we send them off to the laboratory to test for the chromosomes. And remember, chromosomes are kind of the packaging instructions that contain all of the DNA in our body. Most people have 46 chromosomes, XX for females, XY for males. And so that's what this testing looks for. It looks, does this embryo have a normal complement of chromosomes, both in number and in structure? Like, are some parts missing? Are some parts duplicated? Are some parts completely flipped? Things like that. Most miscarriages that happen, especially as you get older, are due to abnormal chromosomes in the embryo. And so it's something that we can't control and is just a pure function of age. And so if we do this genetic testing in conjunction with the IVF, we're able to see out of the cohort of embryos you've created which ones are genetically normal and which ones are not. And we would only then transfer the genetically normal ones. The thought is that this would lower the miscarriage rate. And we tend to see miscarriage rates, when you do this PGT testing, still in the about 10% range. So it doesn't eliminate it completely, but it certainly reduces it, especially if you're older. So I hope that answers your question. Abby asked about the statistical probability of a chromosomally normal embryo for a 40-year-old. So that's a good segue from, what we were just talking about. So she's saying, for example, if 5 blastocysts or embryos develop, what are the chances one may be normal? So again, along with that, higher risk for miscarriage as you get older, part of the reason for that is a higher proportion of a female's eggs are chromosomally abnormal as we age. So in a young person, probably the majority of their eggs are going to be chromosomally normal. But as you get older, especially over 40, probably the majority of them are going to be abnormal. So in a 40-year-old or a 40 and above, I would generally say at least half are going to be abnormal, if not more. But remember that this is population based, right? And so certainly we get patients who, kind of buck the trend and end up having more than expected euploid. That's what we call a normal complement of chromosomes, euploid embryos. And certainly we hope that for everyone, but it's probably realistic to expect at least half of them to be abnormal. Whitney asked about genetic testing on frozen embryos. So this is a really good question because remember when I was talking about doing the biopsy before, it was in the context of what we call fresh IVF cycle, meaning you just did the egg retrieval. We just created the embryos by putting the eggs and sperm together and they're growing in the laboratory. And then on day 5 or 6, we do the biopsy. Usually after the biopsy, because it takes time for that test result to come back, the embryos get frozen, and then you would come back at a later time for the transfer. Now, what if you did IVF already and froze embryos but did not do genetic testing? Can you go back and do genetic testing? And the answer is yes. That's called a thaw, biopsy, and refreeze, which just refers to the different steps. And there might be reasons why you consider that. One of the things, though, to be aware of is by doing that process, you are putting your embryos through a second uh, thaw uh, and freeze and then thaw again. So it's an additional stressor on the embryo. And while, our lab is really excellent and we have very, very high survival rates for when the embryo is thawed, you have to remember that nothing is ever 100%. So there is always a chance, and we quote about a 5% chance when the embryos get thawed that they don't survive the thaw. So if you put them through another thaw process, you encounter that risk again. Furthermore, we actually recently did a study on our patients that looked at people who did the thaw biopsy refreeze, and it showed that actually going through that second stressor of the thaw and freeze cycle ultimately reduced the implantation potential of that embryo, even though it got genetically tested. So and we found it drops it almost by half, which is surprising. Now, that certainly doesn't mean that, that embryo doesn't have a chance. It certainly still does. But that's just something to know when you're thinking about whether you should do that or not. And again, that's another really good discussion to have with your doctor to kind of think about the pros and cons for your situation. All right. Nadine asks, is there any procedure that accepts Medicare for fertility care? Nadine, I assume you mean like, is there any clinic or place that would accept that kind of insurance to get fertility care? Um, and unfortunately, the answer is no. So, when we talk about places like Massachusetts that have insurance mandates, which require commercial insurance carriers to provide some sort of fertility benefit, that mandate does not apply to publicly provided insurances like Medicare, Medicaid, or in Massachusetts, we have something called Mass Health. And so if you have any of those plans, none of them offer fertility coverage. And so generally, you won't be able to have any of that paid for. Um, Now, since you asked the question, I want to put just one caveat to that. So often these types of public plans, Mass Health, Medicare, will not even cover a consultation. So even just meeting with a fertility doctor to ask your questions and get some counseling. And so often that can be beneficial in itself, even if you don't choose to pursue testing or treatment. Now, again, at Boston IVF, we don't take that type of insurance. So if you wanted to do a consultation, it is at an out-of-pocket cost. However, we have a clinic that is run by the fellows at Beth Israel Deaconess Medical Center where we are able to provide that initial consultation for you, even if you have public insurance. Similarly, if your primary care doctor or OBGYN is in the Beth Israel Lahey system and they refer you to us at Boston IVF, the fellow can see you in their clinic for an initial consultation for free if you have one of those public plans. So there are a couple of options if at least you want to get your foot in the door and meet with someone and talk about, your fertility concerns. Okay. Jacqueline asks, is there a recommended number of embryos to transfer if you are using donor eggs? This is a great question. So, um, when when you use donor eggs, usually, people choose to use donor eggs for a variety of reasons, but most commonly it's because you yourself either don't have, a large enough cohort of eggs where you would not get very many eggs through an IVF procedure, or you've tried fertility treatment yourself. Unfortunately, it hasn't worked. So often people go on to use donor eggs. Now, the thing about donors is that they're all young people. And so they all have presumed very good fertility. And again, remember what I said earlier with younger age, the risk of miscarriage is lower, and the risk of genetically abnormal eggs is also lower. So this absolutely applies when we're talking about eggs from a donor. So, because of that, the embryos that are created from donor eggs have the implantation and pregnancy potential of that donor's age. So, usually it's someone in her 20s versus, for example, if you may be 45. So, um, That's why in donor egg patients, we recommend transferring one at a time because each embryo that's created has about a 50 percent implantation potential, or I should say approximately 50 to 60% chance at becoming a baby. And so if you put more than one in, there's a high chance of twins. And we never intend to give to create a twin pregnancy. This, many of you might think that that's kind of a funny statement to make because you hear about all these, you know, triplets, quadruplets, octuplets that resulted from IVF many years ago. And that was the case, historically when our technology in IVF actually was not as good. And so to compensate for that, we put more embryos in. And those unfortunately led to these really high multiple pregnancies. Now, the reason I say that we don't ever intentionally try to create multiple um, gestations is because even though it sounds really great to have twins and be like, oh, yeah, I have my two babies and done in one shot, kind of killed two birds with one stone, it's actually a very high risk pregnancy situation. And so it really puts both the mother and the babies at risk for complications. The mom has various pregnancy complications that she would become at risk for, including, needing to be hospitalized at a very early stage in your pregnancy and staying hospitalized potentially until you deliver the babies. And also very, very high risk of those babies being born prematurely, needing ICU care, potentially very long-term sequela of being born premature. And so, again, because of these significant risks, we don't feel that it is medically prudent to intentionally give someone twins or triplets, what have you. So again, usually the recommendation for number of embryos to transfer is based on age and if you're doing a donor egg, because it's the genetics of the egg that is relevant. The donor is young, so the recommendation is usually one. Okay. All right. So Nene's asking if I can explain the IVF process, and certainly I can do that. So um, for someone who kind of has had no history or no idea about the IVF process, I'll start from the very beginning. So IVF, it refers to in vitro fertilization. So the easiest way to think about this is that we remove the two parts of the two types of cells that are necessary to make a baby, the egg and the sperm. We remove both of them from the man and the woman and put them together in the laboratory. That's the in vitro fertilization part. And then we grow the fertilized embryo in the laboratory. Now, what that actually involves is a number of things. So, IVF cycle usually starts at the beginning of your menstrual cycle. By convention, we call the first day of your period cycle day one. And so usually what will happen is that in a normal menstrual cycle, in a natural one that you may experience every month, um, you have normal hormones that your brain sends to your ovary called follicle stimulating hormone, or FSH. The FSH tells your ovary, oh, recruit this cohort of eggs and start growing the follicles. Now, when I say follicle, think egg. A follicle is essentially like a water balloon that contains the egg inside of it. Okay, and as your brain continues to send the ovary that FSH message, the follicle grows bigger and bigger. In a normal menstrual cycle, one of those follicles becomes the dominant one and continues to grow and eventually becomes the egg that gets ovulated. All of the other follicles that started to grow at the very beginning die off and they go away. In an IVF cycle, we're taking that normal process, that normal machinery that your body has, and just really stepping on the gas pedal. And so you are taking shots of FSH, that same hormone that your brain is producing, plus another hormone that your brain also produces called LH, or luteinizing hormone. And both of these help grow the follicles and helps mature them in the egg in the end. Now, remember that I said in a natural cycle, usually only one or two eggs eventually develop, all of the rest of them die off. In IVF, our goal is to prevent all of those other ones from dying off, and we want all of them to grow. And so, by giving you high doses of FSH and LH, higher than what your body naturally produces anyway, we want to recruit all of those eggs so that they develop. During that process, while you're giving yourself those shots, you come into our office every few days or so for blood work and ultrasound. And the blood work and ultrasound are to monitor your hormone levels and also to measure the size of those follicles as they grow on your ovaries. Once the size gets to a certain point, your hormone level also, gets to a certain level, your doctor will say, okay, now it looks like these eggs are ready, and they will tell you to take another shot called a trigger shot. That trigger shot is what causes the final maturation of the eggs and prepares the eggs to be released or ovulated. Now, we obviously don't want you to ovulate these eggs because if you ovulate them, we lose them in your body. And so the timing of the trigger shot is very important. You will take the trigger shot and then 36 hours later come in for your egg retrieval procedure. And this gives us enough time to take all of those eggs out of those follicles before your body ovulates them. Once we take the eggs out of your body, your partner, or if you're using a sperm donor, the sperm source, we would take the sperm and mix the eggs and sperm together in addition the laboratory. And it takes about a day or so for them to fertilize. The next day, we'll check to see how many fertilize. And then over the next 5 to 6 days, we will watch them grow in the laboratory. And at the end, either the embryo or embryos will be transferred back into your uterus, or they might be frozen and used in the future. Okay. All right. Nicole is asking, is it true that women over 40 are less successful getting pregnant with frozen embryo transfers rather than fresh? So, um, Nicole, I don't think that's true, but maybe the reason that you might have heard something like that is because remember the process that I just talked about in IVF, and there's many steps to it, and at each step there is an attrition or a drop off in kind of the number of eggs, number of embryos that you get. So, for example, let me give you some hypothetical numbers just to make the case. So say in the egg retrieval process, you get 10 eggs. That's a pretty good number, 10 eggs. However, not all of these eggs are going to be mature, okay? So we say about 70 to 80% generally are mature, and only the mature eggs can get fertilized. So out of your 10 eggs, we'll say maybe only 8 of them are mature, which means at most only 8 can become embryos. Now, fertilization, again, is generally about 70%. Nothing we do is 100%, and you have to remember that. So now, again, out of the 8 that were mature, the 8 eggs that were mature, let's say at best, 5 or 6 fertilized. We'll say 6. So now 6 out of the 10 that you got originally have fertilized, which means that they are now embryos and can start growing. Remember, though, that the growth process takes several days in the laboratory. And ideally, where we want to get to is a stage of embryo development called the blastocyst stage, which is day 5 or 6 of embryo development. However, there is a big attrition between fertilization and the blastocyst stage as well. And generally, we say only about half of the starting embryos make it to the blastocyst stage. So you had 6 embryos that fertilized, and so now based on that 50% attrition, at the end of the day, you may only get 3 that are blastocysts, which can be transferred or frozen. Now, when you're older, there are 2 things working against you, unfortunately. Both the quantity of eggs that you may start off with, and then also the quality of eggs, which are kind of the genetics that I talked about earlier. So not only might you start out with a lower number of eggs, but more than would be abnormal. So in a 40 plus year old, maybe, for example, you only get 5 eggs. And so at the, kind of take that math all the way out to the end, maybe you only end up with 1 usable blastocyst, or potentially none of them make it to the blastocyst stage. And so you don't even have an embryo to freeze and use for a frozen embryo transfer. If you choose to do a fresh transfer, you can kind of reduce some of that risk of not having an embryo that makes it to the blastocyst stage, because at Boston IVF we also do day 3 transfers. And so this is transferring an embryo at an earlier stage before it gets to the blastocyst, or day 5. And some of the rationale for that is, in patients who may not have good embryo growth in the laboratory, that if we waited, they would either arrest or not develop, maybe because the artificial laboratory environment, isn't as optimal compared to your uterus. And so we may choose to transfer those embryos earlier on day 3 back into the uterus. And that gives you a chance at a transfer and potential pregnancy. So that might be why, you're thinking that in older patients above 40, doing a fresh transfer might actually be more beneficial than frozen embryo transfer. And that's certainly I think a valid thought. But I don't think there's any data that actually says that, if you can get to a blastocyst and have an embryo to transfer, that it's actually significantly different. All right, we only have a couple minutes left here, so let me just take a quick scroll through the rest of the questions. All right, I think there's some questions about all right, egg quality versus sperm quality, which is always a conundrum that we're facing. So Melissa is asking, She did PGTA testing with IVF, and she knows that age could be a factor. Um, but is there a way to really know if, the unsuccessful, um, the cause for unsuccessful cycle was because of egg quality or sperm quality? And that's a really great question, Melissa, and one we frequently struggle with as physicians when, unfortunately people fail cycle after cycle. You're right in that, especially if you're older, usually the culprit is the egg, and most of the time that's probably correct. And usually, sometimes there are ways we can tell. So, for example, the embryologist might make a notation that when they actually look at the eggs under the microscope, they look a little abnormal, or when the fertilization happens, there's just something abnormal about their appearance, and that may give a clue that the egg quality isn't as good. Another way that we frequently kind of distinguish egg versus sperm quality is how the embryos grow in the laboratory. So remember I said that there's on day 5, there's a blastocyst. That's kind of the time point that we look at. And then on day 3 is another time point that we look at. So the interesting thing about embryo development is that in those first few days, right after fertilization to about day 3, everything that the embryo needs to develop is completely from the egg. So up to about day 3, it hasn't used any of the genes that the sperm has contributed to it yet. And so um, and then after that, after day 3 to day 5, then all of the genes that that embryo received from both the mother and the father kind of come into play and influence the development. So if we see normal growth of the embryo up to day 5, and then really poor development from day 3 to day 5, then that gives us an inkling that maybe the sperm here is at play, because it seemed to develop totally fine when, the egg genes were kind of the dominant ones, but then once the sperm genes also contributed, the growth didn't seem to be as good. Now, by no means is this definitive, but kind of based on what we understand about embryo development, this is the theory. Some other ways that you can test sperm quality are there other specific sperm testing that can be done, and you can talk to your doctor about this. In addition to the routine semen analysis that we do, there are other specific sperm tests like DNA fragmentation that can look at, the different aspects of sperm quality. Um, these are still relatively new tests in the fertility field, though, but there is some emerging evidence that, increased DNA fragmentation in sperm does contribute to poor outcomes. Um, but a lot of the times the test ends up being normal, and so it doesn't necessarily give you that much more additional information, um, because it doesn't eliminate the fact that the sperm might still be the issue. So I hope that helped a little bit, but essentially the answer to this question is very, very difficult to figure out. And essentially we, as the experts, still don't really have great ways to figure that out either. All right, I know there are still a lot of questions, and I'm sorry I wasn't able to get to all of them. Um, One person did ask, if spouses or partners are allowed in the procedure rooms now, and that's a quick answer, so I'll just tell you, yes, we recently did just start allowing partners back into the transfer, so that's really, really great. All right, so again, if you guys have Sorry, again, sorry for the questions I didn't get to. Please feel free to look at our website. You may be able to find a lot of the answers to your questions on our website. And of course, you can always contact us and schedule an appointment to talk about your specific situation in more detail. But thank you for being with us tonight, and I really enjoyed hearing from all of you. Take care, everyone. Bye bye.